Professor Rizvi, respected panelist and speaker, distinguished participant. Assalamu alaikum. আজকের হাইপারটেনশন উপরে এই ইম্পর্টেন্ট সেমিনারে আমাকে আমন্ত্রণ জানাবার জন্য কৃতজ্ঞ। Hypertension is a silent, and amongst 20 to 25% adult population have got hypertension. Many do not know, and suddenly they are landed with stroke, heart failure, kidney failure, or blindness. So anyway, this is known to us. We know it. We are ignorant, indifferent, do not take care of it, and we are suffering from this hypertension, which can be prevented many if we take due measures. We will have to tell people again and again about this, because usually when people get suffering, pain or anything, they take medicine. But without any pain or anything, not care for it. So this seminar is very important. I am sure if we can detect in, we will take due measures, take less salt, maintain weight, and do physical activity, do not smoke. You can live stressless life, then and then you can relieve from this disease. Even after this, there will be some people who will get hypertension. They will have to be treated. And for this, I am sure treatment is available. Government is making, Heart Foundation organization are trying to do. I am sure today this will be discussed, and I am sure if all of us take care, take note of this, we know, let other people know for this and take care, then we can prevent and keep our people free from this dreadful complication and diseases. So I have got some other function, so I will have to leave. I thank the speakers. I will have to be very happy if I could hear to them. I am sure they will speak very nicely everything. And those who are listener, participant, please, that we should take seriously. We know many things, but we take action. Action is very important. So my advice will be, all of you know already. You will have to tell people again and again, take medicine, and half-heartedly you take medicine sometime and do not take, it will not be useful. So action is very important. So I wish the success of this meeting, inshallah, then a failure depends on activity. So I hope we'll do our activity, and already Heart Foundation, government, health, DG Health, they are moving in this direction. I'm sure it will be discussed in this meeting. 54 Upazila hypertension treatment has been started, detection treatment, and government is giving free treatment. And we hope, inshallah, within next few years, Bangladesh will make hypertension under control and people be free from full complication, stroke, heart failure, kidney failure. Thank you very much, and I'm sure it's useful. Thank you very much. I thank Navana Pharmaceutical for arranging this important seminar. Thank you very much. Thank you.
Malik has left us, but all our respect for Brigadier Malik, who is the president and founder of National Heart Foundation of Bangladesh, and who was also the chairman of today's scientific meeting. I would like to express my respect to all the other chairpersons, the speakers, and the participants, and also my deep respect for these panelists. Okay, assalamu alaikum and good afternoon. This National Heart Foundation has set up a week-long program to observe the World Heart Day 2021. This meeting is a part of that program. I feel myself very privileged to be able to join in the host of star cardiologist of Bangladesh. We know that hypertension is a major cause of heart diseases and its mortality and morbidity. And in fact, about 13% of all death in the world is due to hypertension. And in fact, it is projected that there will be about 30% increase in the incidence of the hypertension in the next by 2025. And Brigadier Malik has mentioned that we have a huge number of people is suffering from hypertension. It is about 1 in every 4 persons. And alarming is that of those, about 50% do not know they have hypertension. And another alarming fact is that many of those who were suffering from hypertension and taking medicines, of them, only 13% takes medicine regularly. So this is a huge burden. And this has made a big challenge for all of us. The challenges are manifold. The number one challenge is we do not truly know the number of people suffering from hypertension, so we need to have a nationwide surveillance. Another problem is who are suffering, we need to treat them. And treatment is difficult because many of our patients cannot afford medicines, so we have to provide free medications. Medication is not enough. We have to follow up the cases because there is a large number of dropouts, and there may have complications. So we'll have to look after these complications as well. So we are facing these challenges, and this is a huge task. Government alone cannot do that. So National Heart Foundation, from the beginning, we are working with the government and other organizations to help people in these regards. The National Heart Foundation has so many programs. We have many preventive programs. We have curative programs, and we have research programs as well. Brigadier Malik has mentioned that recently we have started a joint program organized by the government of Bangladesh, National Heart Foundation, and Resolve to Save Life to identify, to treat, and to follow up the cases in the Upazila level. And initial pilot project was in 4 Upazilas in Sylhet, which has become successful. Depending on that success, we have extended this program in 50 Upazilas. If this can run well, we have a plan to expand this program nationwide. If we can do that, that will be a significant achievement for all of us. So I am very hopeful that if we can continue these programs, definitely we will be able to. Brigadier Malik has also mentioned that if we can cover whole Bangladesh, then we will be able to manage hypertension to a large extent. But this most important thing is that before we go for this definitive programs like joint programs we have to start it, will have to depend mostly on preventive programs. Curative programs is always expensive and difficult. Curative programs, especially if we can ask people repeatedly to, to change their lifestyle. If we can change the lifestyle, if we can maintain a healthy lifestyle, then definitely we'll be able to avoid hypertension to extent. Okay, I am not going to extend my speech any further. I would like to thank everybody who has joined us in this meeting. Thanking you. This is the end of my speech. Thank you.
We held a small ceremony. I would like to start that again. Navana Pharma feels privileged to honor National Professor Brigadier Malik sir for his vision and contribution to cardiology. They would like to present a token of honor to sir, which will be received by Professor Fazila Malik on behalf of Brigadier Malik sir, and it will be handed over by Dr. Saeed Ahmed, Director Sales and Marketing of Navana Pharma. Thank you, madam. Thank you, Dr. Saeed Ahmed. Now, I hope we are through our over our technical problems. We can start our lectures now. The first speaker for the day is going to be Professor Dhiman Bonik, sir. He will be speaking on definition, pathophysiology, and signs and symptoms of hypertension.
Hello, can you hear me? Sir, can
Yes,
you hear me?
yes, we can hear you, please.
Respected chairpersons, respected panelists, teachers, colleagues, and friends. Today, my presentation is on definition, pathophysiology, symptoms, and signs of hypertension. At the beginning, I want to start with a case. A young lady of 35 years came to our outdoor with a blood pressure checkup. His blood pressure is 146/92. What will be the next evaluation of this patient? This recording is the first time, then we cannot say it as hypertension, as because only first reading is not an definitive diagnosis of hypertension. So this patient should again come to office visit or to the hospital or to a clinic at 1 to 4 weeks, within 1 to 4 weeks, or 2 to 3 visits. And if these subsequent visits shows that his blood pressure is more than 140/90, then we can say lady has hypertension. The diagnosis of a single visit hypertension is is 180/110 millimeter of mercury. In a single visit, if the pressure is 180/110, more than 110, and there is evidence of cardiovascular disease, this one visit of blood pressure measurement, the patient is hypertensive. And if anyone have any reading, documented reading of blood pressure greater than 140/90 in repeated visit, documented visit, that patient can be said to be hypertensive. In the last 2 or 3 years, the cutoff value of hypertension is being confused by all. Recently, in 2020, International Society of Hypertension had revised this value. It is as before, more than 140/159, and 90/99 is hypertensive. Normal is less than 130/55, and in between it is high normal. Systolic hypertension is to be said when systolic blood pressure is more than 140/140, and diastolic blood pressure is less than 90, and it is commonly found in young elderly people. I want to say one line about the depth of the disease. Raised blood pressure remains the leading cause of death globally, accounting for about 10.4 million deaths per year. It is the latest value. Regarding my main topic on pathophysiology of hypertension, primary and essential hypertension is a multifactorial and complex mechanism of disease mechanism. 4 important mechanisms comes into play: activation of the sympathetic nervous system, vascular endothelial dysfunction, renin-angiotensin-aldosterone system, and endocrine system. There is inappropriate high sympathetic drive from the brain due to stress, that of the increased catecholamines level, which causes increased large arterial stiffness. And this large arterial stiffness occurs in the artery, in the media, and the media to lumen ratio is increased. And this is the important sign of hypertension. And this causes increased systemic resistance. As there is increased sympathetic drive, the heart, there is increased beta-1 stimulus, so the high cardiac output is there. There is abnormal salt mechanism in the kidney, and there is increased high venous return and vasoconstriction in the venous level. And these all causes hypertension due to inappropriate secretion of sympathetic drive. The increased sympathetic drive causes several types of hypertension. First one is the obesity-related hypertension, important cause of increased sympathetic drive. When there is weight gain, the reflex activation, reflexly sympathetic drive is increased due to compensation for the burnout of the fat. And this sympathetic activation is also increase insulin resistance. There is an important remark regarding this. Due to the weight loss due to obesity, hypertension improves, but the diabetes remains, diabetes does not improve. And this is the mechanism of syndrome, metabolic syndrome in obesity. Another important findings of sympathetic drive in hypertension is the obstructed sleep apnea. In obstructed sleep apnea, it is the emerging risk factor for coronary artery disease, and it is the modifiable risk factor for hypertension. Regarding the frequent nocturnal arousal of obstructed sleep apnea, there is fragmented sleep at night, and the daytime there is sympathetic excitation regardless of the obstructed sleep apnea severity. This accelerated hypertension, which complicates with atrial fibrillation and stroke. Another important sympathetic drive is due to fetal malnutrition. In fetal malnutrition, there is low birth weight and reducing nephrogenesis of the kidney. And this causes the functional nephrons to be underdeveloped. And when the patient grows and they consume fast food diet, and there is postnatal weight gain leading to adolescent obesity and hypertension. The most important pathogenesis is the renin-angiotensin-aldosterone symptom, which is important in developing the renal endothelial dysfunction. In this, renin is a substance secreted by the juxtaglomerular cell of the kidney, and this convert an important renin substrate angiotensinogen to angiotensin 1. And this angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, which is mostly present in the lung and in the heart and in the vascular endothelium. And this causes this angiotensin 2 acts on angio-81 receptor, and this causes increased sympathetic activity, and this causes increased endothelial dysfunction. Smooth muscle inflammatory response comes into play, and there is increased cell growth. And in the kidney, causes sodium retention, which causes hypertension. In the adrenal cortex, it causes corticoid activity, and there is increase in the hypertension. And the vascular mechanism mainly occurs in the small and large artery, and it is the pivotal pathogenesis and progression of hypertension. There is an enhanced release of endothelial derived factors, which are pro-inflammatory, prothrombotic, and growth factors initiation. Now the symptoms of hypertension. Hypertension is this. It is told that hypertension is a silent killer. There is no specific symptom for hypertension, so the patient are not aware of developing hypertension, and there are even no warning signs of hypertension. When symptoms occurs, there is early morning headache may occur. There may be nose bleeding. There may be irregular heart rhythm. Vision is impaired due to the involvement of retinopathy due to hypertension. There is buzzing of ears. When severe hypertension occurs, it causes fatigue, nausea, vomiting, confusion, anxiety, chest pain, and tremors. Now the physical signs of hypertension. Physical signs of hypertension is important in the indicator of potential causes of secondary hypertension, signs of comorbidities, and hypertension-mediated organ damage. The important examination should be there. Their measurement of the weight, height should be measured, and there will be calculation of the BMI, and the signs of HMOD should be detected. Neurological examination with cognitive status should be determined. During neurological features, we should be important. HMOD is the cerebrovascular disease due to infarct or hemorrhage, and there should be focal neurological signs should be detected. Fundoscopic examination due to hypertensive retinopathy should be evaluated, and the heart and carotid artery should be auscultated. In the auscultation of the heart, there may be a flow systolic murmur due to hypertension, and in hypertension there may be a murmur of aortic regurgitation, which is reversible. The carotid bruit may be present. Palpation of the peripheral artery should be done to detect whether there is atherosclerotic in the peripheral vessel, and there should be comparison of pressure measurement in both arms and legs. This is the important way of measuring the blood pressure. You all know. I want to only recapitulate it. Before measuring blood pressure, a patient should be avoid 30 minutes from smoking, coffee, and exercise, and he should be relaxed for 3 to 5 minutes. And the patient can be measured with sitting or in lying position. If the patient is sitting, the feet should be on the floor, and the arm should be bare, and mid-arm should be at the level of the heart. Patient should not talk during the measurement of the blood pressure, and there should be cuff measurement should be normal. It would be this as size of the patient. It may be small or large. This is the important slide of hypertensive retinopathy. First slide is about silver wearing and copper wearing. And the second one is due to aortic nipping, and there is a Himalayan exudate. There is then, and the last one is the papilledema. The second, about the signs of secondary hypertension, a skin infection is important. The cafe lead spot during pheochromocytoma, and important point is that if a patient has paroxysmal hypertension, this is an important finding in case of pheochromocytoma, and this is the cafe de lot spot patch. And kidney should be palpable or regularly in a patient with hypertension or finding of secondary hypertension. Renal bruit and the size of the kidney should be evaluated. I have mentioned the heart and renal arteries, comparison of the femoral artery. In patient with Cushing syndrome of acromegaly, the signs of Cushingoid phase, the patient obesity, and their, in case of thyroid, the thyroid, hyperthyroid and hypothyroid both may cause hypertension. This should be evaluated by taking some history and examination of the heart and hearing the carotid reflex should be seen in this patient for relaxation in patients with hypothyroidism. So at the end, the take-home message is the prevalence of hypertension rises dramatically with increasing age. 20 millimeter rise of systolic blood pressure and 10 millimeter rise of diastolic blood pressure were each associated with doubling the risk of death and stroke, heart disease, and other vascular disease. Uncontrolled hypertension may cause dreadful hypertension-mediated organ damage, which are really fatal. So early detection and proper management of this dreadful disease can decrease the morbidity and mortality of the patients. Thank you all for patience hearing.
Thank you very much, Professor Dhiman Bonik, sir. Our next speaker is going to be Professor Ashok Kumar Dotto. His topic of discussion is investigation and complications of hypertension. Ashok, sir, please.
Thank you, Dr. Tawfiq Shahid. Honorable Chairperson, respected panel of experts, all my teachers and audience, good afternoon. My topic is complications and investigation of hypertension. I'll describe the complication first because that will make the things easy for investigation subsequently. Next, please. So what are the complications of hypertension? Already Professor Dhiman Bonik described. Yes. So complications of hypertension may be acute in the form of hypertensive crisis, that may be hypertensive emergency, urgency, and sometimes a special term called malignant hypertension. আগেরটা আনশেয়ার করতে হবে। Sorry for inconvenient. So now, yes, next please. So hypertensive complications may be in the acute form hypertensive crisis, including hypertensive emergency, urgency, and sometimes malignant hypertension. Chronic complication is more common. Hypertensive heart disease, maybe stroke or white matter ischemic changes in the brain, maybe chronic renal failure, retinopathy, and sometimes vascular disorder, including aneurysm, aortic dissection, and peripheral vascular disease. So these are the three major organs that commonly affected by hypertension when it is untreated, like the diabetes. This is a systemic disorders on its cardiovascular system, kidney, and brain. The things that happens in the kidney is proteinuria related to the nephrosclerosis. And this proteinuria, either in the form of microalbuminuria, is the early sign or predictor of complications related to heart and brain. And this patient ultimately developed chronic renal failure, maybe in the end stage renal disease. But fortunately or unfortunately, most of this patient does not goes into the end stage renal failure and hemodialysis, because before development of this stage, this patient usually dies either from cardiac death, either from sudden cardiac death, heart failure, ischemic heart disease, or from the stroke. And left cardiovascular effect of chronic hypertension for a long time includes left ventricular hypertrophy that may lead to myocardial infarction or other ischemic heart disease, heart failure, or arrhythmias. And in the brain and in the retina, that may produce the stroke, either in the ischemic or in the hemorrhagic form, and that may produce retinopathy, as already described by Professor Dhiman. So this is the hypertensive heart disease that start with pressure overload. That is a common belief, but most of the patients with hypertension have some form of fluid overload, especially those who have renal impairment. And this overload produces the overload on the left ventricle, leading to left ventricular wall stress that produce multiple effects like neurohumoral activation of renin-angiotensin system, activation of the sympathetic nervous system, as well as mechanical stress will produce left ventricular hypertrophy. Left ventricular hypertrophy will produce some other impairment, including the left ventricular diastolic dysfunction, and it long run may produce systolic dysfunction as well. And ultimately, the clinical effect that happens at the arrhythmia, heart failure, and ischemic heart disease. Ultimately, this is the clinical scenario. And this is the pathophysiological effect. Hypertension may produce hypertensive heart disease. So earliest change that happens in hypertensive heart disease is the LV diastolic dysfunction. In echocardiography, commonly that is described as left ventricular diastolic LVDRA, means left ventricular relaxation abnormality. That can be diagnosed by color Doppler echocardiography, but tissue Doppler imaging is more sensitive for diagnosis of relaxation abnormality. And ultimately, the left ventricle become hypertrophied. And there are some other changes that happens in the heart that includes the muscles that become hypertrophied, and there is some apoptosis of the muscle producing fibrosis in the muscles. In the coronary system, other than epicardial coronary atherosclerosis that we commonly cause coronary artery disease, other things also happens that reduces the vasodilator reserve of the coronary artery, that are the medial hypertrophy, perivascular fibrosis, and capillary rarefaction. So many patients with hypertensive heart disease and also in diabetic heart disease, epicardial coronary may remain normal, but the patients suffer from ischemic heart disease evidenced by ECG, sometimes echocardiogram, and treadmill exercise test. But in coronary angiogram, epicardial coronary seems to be normal. So this is the cerebrovascular disease that may occurs in hypertension, that may be either in the ischemia or in the hemorrhage. 80% of the stroke related to the ischemia, either by thrombus in situ or by embolic phenomena, and 20% is only hemorrhagic. But 50% of the all strokes happens due to hypertension only. Other things that happens is the carotid arthrosclerosis that already described by Professor Dhiman Bonik. So carotid arthrosclerosis, carotid aneurysm, each and every patient should be auscultated in the neck. Some of the changes with the advance of investigation, especially MRI, we see the white matter ischemic changes that ultimately sometimes may lead to cerebral atrophy and vascular dementia. These are the retinopathy, already been described very perfectly by Professor Dhiman Bonik. Now, I will not go in details of it. But anyhow, if any patient develop hypertensive retinopathy, that is an independent predictor for cardiovascular risk and cerebrovascular incidence as well. And any patient having the papilledema with severe hypertension, blood pressure more than 180/110, that indicates very emergency or urgent treatment of hypertension. Otherwise, this patient may develop blindness, may develop encephalopathy, stroke, heart failure, or coronary events. So hypertensive nephropathy is characterized by nephrosclerosis, that is histologically, and there may be microalbuminuria, that is also sensitive marker like retinopathy for cardiovascular events. So though it is called microalbuminuria, amount of albumin that passes in the urine over 24 hours is 30 to 300 milligrams. So that is actually misnomer. That should be moderate albuminuria. Hypertensive vascular disease may be in the simple form of unfolding of the aorta that may be detected by chest X-ray, dilatation of the arch of the aorta. There may be aortic dissection, abdominal aortic aneurysm, and peripheral vascular disease clinically manifested at limb ischemia. So what are the investigation that you need for hypertension? As we know, more than 90% of the patient with hypertension are cause unknown or idiopathic or primary. So only few lab investigations necessary. So most of the investigation that we usually select, that is for other region, for important factor that is essentially drive us to go for investigation at secondary hypertension when we suspect, in case of resistant hypertension, and to assess the cardiovascular risk factor like diabetes, dyslipidemia, and others, and to find out the complications related to hypertension that are commonly called target organ disorders. Hypertension is the disease that can be diagnosed at bedside or at office without any laboratory facility and without any extra cost. And 24 hours ambulatory blood pressure sometimes very much useful, especially in white coat hypertension, mask hypertension, to rule out or to confirm the diagnosis in some special situation where the perfect control of hypertension is very much essential, like ischemic heart disease, patient with heart failure, patient with stroke, and renal impairment. And nighttime blood pressure more than 110/70 in 24 hours and preferably 48 hours ambulatory blood pressure indicates the patient is at best. Average value more than 130/80, the patient should be diagnosed as hypertension. Investigation that would be advised the urine analysis that on albuminuria or proteinuria, presence of RBC. If we ruled out the other cause of RBC from the renal or ureteric stone or other cause of hematuria, that indicates hypertensive crisis. Sorry. Presence of glycosuria indicates indicates diabetes mellitus. TBC as a part of routine investigation, diabetes and fasting lipid profile as an assessment of the cardiovascular risk factors. Serum creatinine and electrolytes sometimes helpful. Creatinine or maybe the cause or effect. Cause means hypertension may cause renal impairment, and sometimes renal impairment due to diabetes or other region may produce secondary hypertension. So we have to find out which one is the cause, which one is the effect. In certain cases, it is very much difficult to find out, and in certain circumstances, it is really cumbersome. Which one is the effect, which one is the cause? Serum electrolyte, especially, it is important when we prescribe diuretics and ACE inhibitor because of electrolyte imbalance. And serum uric acid, especially, it is important when we prescribe diuretics because thiazide diuretics is relatively contraindicated in case of hyperuricemia. Next, please. So then ECG and chest X-ray. Chest X-ray is not essentially needed for workup of uncomplicated hypertension, but sometimes it may give a lot of clue, especially in advanced cases of hypertension and long-standing cases by left ventricular hypertrophy or cardiomegaly. There may be unfolding of the aorta, there may be widening of the descending aorta. ECG is a very important tool, specific and less sensitive, especially for diagnosis of left ventricular hypertrophy, diagnosis of ischemic heart disease, and sometimes arrhythmia. Echocardiography, that is already I have described. Early diagnosis of diastolic dysfunction, diagnosis of left ventricular hypertrophy, and sometimes diagnosis of left ventricular dysfunction, diagnosis of ischemic heart disease. This is important. Two other things that is very much important is enlargement of the left atrium that may happen in many patients with hypertension before developing LV systolic dysfunction because of LV diastolic relaxation abnormality. Left atrium have to pump against higher LV EDP. So left atrial enlargement is the consequence of left ventricular diastolic dysfunction that ultimately lead to atrial fibrillation. So worldwide, hypertension is the commonest cause of atrial fibrillation, though in our subcontinent, rheumatic heart disease is the common cause. But worldwide, hypertension is the commonest cause of chronic atrial fibrillation. Ultrasonography usually that indicates glomerulosclerosis characterized by change of echogenicity of cortex and medulla, producing loss of corticomedullary differentiation, increased echogenicity, and reduced cortical wall thickness. For diagnosis of the secondary cause of hypertension, like structural heart disease, including polycystic kidney disease, presence of hydronephrosis, sometimes diabetic nephropathy. As you know, diabetes is the commonest cause of chronic kidney disease, and chronic kidney disease is a cause of hypertension, secondary hypertension, and sometimes resistant hypertension. And sometimes asymmetrical kidney size indicate renal artery stenosis in on-site. Additional specialized investigation, that is when the clinical picture and routine laboratory investigation suggest secondary hypertension or suggest complicated hypertension like resistant hypertension, hypertension with target organ damage. These are the investigation to find out the renovascular hypertension. Renovascular hypertension means hypertension because of renal artery stenosis, either unilateral or bilateral. That may be due to two reasons. One is atherosclerosis, commonly involve the ostium of the renal artery, either unilateral or bilateral, and other is the fibromuscular disorder that usually spares the ostium of the renal artery, but the shaft and the branches are more commonly affected with a string of bead signs. Duplex study, ultrasonography duplex study is helpful for diagnosis, but definitive diagnosis and structural and abnormality most perfectly detected by either CT angio or by conventional angiogram. In the ultrasonography, kidney usually shrinkage that may be the bilateral or unilateral depending on the site of stenosis. This is the coarctation of aorta. That is common. That is uncommon cause of coarctation, common cause of secondary hypertension. But clinically, we suspect when upper limb hypertensive, lower limb blood pressure is low or undetected. So that is the post-ductal coarctation. Sometimes right arm shows the high blood pressure, left arm there is no blood pressure or very feeble pulse that indicates preductal coarctation of the aorta. Definitive diagnosis, definitively angiogram, either CT angiogram or conventional angiogram, but suprasternal echocardiography, color Doppler is very much sensitive and effective for diagnosis of coarctation. This is the special investigation, especially for secondary hypertension that sometimes called endocrine hypertension, that are the pheochromocytoma, Cushing syndrome, Cone syndrome, paraganglioma, hypoparathyroid, hyperparathyroidism, and acromegaly. Pheochromocytoma, clinical suspicion is very much important for pheochromocytoma. 4P, usually we say paroxysmal palpitation with perspiration or diaphoresis that happens paroxysmally, and patient sometimes anxiety disorder looks like panic attack. So this is paroxysmal palpitation, perspiration with panic-like attack, along with pallor and postural hypotension and headache. These are the pieces that happens in pheochromocytoma. Though it is called paroxysmal, but more than 50% of the patient with pheochromocytoma, persistent hypertension is usual. And urinary 24 hours VMA metanephrine examination and urinary plasma metanephrine detection is important investigation tool. Ultimately, the diagnosis should be confirmed by either CT scan or by MRI. Second is the Cushing syndrome that can be diagnosed by urinary precortisol level or cortisol in the serum. Hypothyroid detected by serum T3, TSH, and T4. Hyperparathyroidism by parathormone level. Acromegaly by growth hormone. And all these cases, when the tumor is suspected, CT scan and MRI is ultimately for morphological or tumor diagnosis is very important. MRI is especially important when the suspected tumor is located close to the skeleton. With this, I like to thank everybody.
Thank you very much, Professor Ashok Datta, sir. To keep the flow of the seminar ongoing, we will take questions at the end of all the lectures. So our next speaker is going to be Professor Fazilatun-Nisa Malik. She will be speaking on the treatment aspects of hypertension.
Friends and colleagues, it's indeed a great pleasure and honor for me to be here today. And today I'll be talking about treatment of hypertension. Now, the question might be, why do we need to treat hypertension? And we all know the answer is because hypertension kills. And indeed, hypertension, high blood pressure is the leading condition that causes death even more than all infectious diseases combined. And when we can reduce the blood pressure, obviously we can reduce both cardiovascular as well as renal mortality for our patients. But unfortunately, most of our hypertensive patients do not have their blood pressure under control. And it has been found that globally, less than 14% of the population who are hypertensive actually have their blood pressure under control, which is truly a tragedy. The slide isn't moving and there's an extra line. The slide is stuck here. Can someone do something about that? Okay, right. So now it's moving. And how do we treat hypertensive patients? And obviously it is by lifestyle interventions and antihypertensive pharmacotherapy. And I think here a physician has such a vital role to play. Please do not change the slides. I'll do it myself. Yeah, yes. So we have to treat our patients properly, and we really need to motivate our patients. If we do not motivate our patients, no one's going to listen to us about lifestyle interventions or about taking drugs, which in many cases, if a patient is asymptomatic, he will deem unnecessary. So if you look at the lifestyle modifications, what are these? These are very time-tested maneuvers like weight reduction. And indeed, if someone reduces 1 kg of weight, that translates to 1 millimeter reduction in blood pressure. So you can imagine if someone loses 5 kgs in weight, they automatically lose 5 millimeters of blood pressure, which is phenomenal, almost as good as any excellent antihypertensive drug. Then to eat sensibly, to avoid saturated fat, to consume more fresh fruits, vegetables, legumes, etc., and to avoid a fatty diet. Dietary sodium. Now in Bangladesh, actually, we have a very high salt intake. In fact, the average Bangladeshi takes 10 grams of salt per day, whereas the WHO recommendation is 5 grams per day. So it's almost double. So we really need to motivate our patients not to take extra sodium. And physical activity. This is something that we've almost forgotten. Most of us lead very sedentary lifestyles, stuck to our computers, our cell phones, or the television, and we really need to change that. So we have to motivate our patients, and also including ourselves, to walk at least 30 minutes each day. And these things can really pay dividends, because all of these maneuvers translate to losing 3 to 5 millimeters reduction in blood pressure, which if combined can really work wonders. So after all these lifestyle modifications, we have to go to drugs. And the drugs we obviously remember with the acronyms of A, B, C, D, and E. The A stands for AC inhibitors at ARB, B for beta blockers, C for calcium channel blockers, D for diuretics, and E is for etc., which includes alpha blockers like prazosin, centrally acting drugs like clonidine, or direct vasodilators like hydralazine. So if we come to the first, in the A, which is the AC inhibitors. So we have long-acting AC inhibitors like ramipril or perindopril, and we've got short-acting like captopril. The long-acting drugs are obviously suitable for sustained and smooth blood pressure control, and the short-acting are suitable for initiation of therapy when the patient is hospitalized. In case of the ARBs, we know that these are very popularly used drugs, and in many instances in combination. Regarding the amlodipine and the other calcium channel blockers, these are one of the most widely prescribed drugs globally. Why? Because these are metabolically neutral. We really do not have to watch over the creatinine or the electrolytes, which is great. We can give this to CKD patients. It improves cerebrovascular mortality. But the downside with amlodipine, which is so widely prescribed, is that it causes ankle edema. And in fact, in higher doses, it can lead to 10% patients might suffer from ankle edema, which is really quite worrisome for the patients. And today our next, the last speaker will be highlighting how we can overcome this and what new drugs have come to overcome this angle edema problem of amlodipine. Could you again move the slide for me? It's stuck again. Please go to the next slide, please. Thank you. Now, the next is the diuretics. Either it can be thiazide type diuretics like chlorothiazide or thiazide like diuretics like indapamide. But obviously, you have to monitor the electrolytes, and giving this to patients who suffer from gout, diabetes, or dyslipidemia might not be the best possible choice. Beta blockers very widely used for a variety of reasons, but the available evidence does not support the use of beta blockers as first-line drugs in the treatment of hypertension. But definitely beta blockers are indicated in patients with established coronary artery disease, heart failure, arrhythmias, or patients who have a very high sympathetic drive. So how do we choose a drug for our patients? There are guidelines indeed, but each patient is unique, and we have to remember that. Not only do we have to motivate our patients to continue the drugs, but we have to assess what works for our patients. Like if a patient is very anxious, has tremor, maybe beta blockers might be of use. If the patient has bronchial asthma, obviously that would not be a good choice. If the patient has heart failure, then we would give these patients diuretics, AC inhibitors, ARBs, aldosterone antagonists, or beta blockers. For diabetes, obviously AC inhibitors and ARBs work very well. And so you go around and see what works for your patient and you prescribe that. So overall, the main benefit of antihypertensive drugs is obviously on how perfectly we can obtain the optimal blood pressure and we can maintain without causing any side effects for our patients. Our patients will not take the drug if they have any side effects, so they'll just stop using it. And using a once daily dose works really well for the patients because no one wants to take a lots of tablets. We should, when we start antihypertensive drugs, we need to wait for 5 to 7 days to get optimal drug effect. And we have to assure our patients about that as well. Sometimes patients get very worried, very restless. I'm taking the medication, why isn't my pressure coming down? But we should allow at least 4 weeks before we evaluate. And when all is equal, if the cost is equal, then we should try to use combination drugs. And always we should go for the least expensive drug because this is a lifetime commitment. Our patient will not be motivated in the most of the instances if we insist on a very expensive drug. Now, what is the rationale for giving combination therapy? Because when we use a combination, it will have additive effects and there is synergistic effects, especially with the use of diuretics. There will be a reduction in the adverse events, and with low dose strategy, there will be enhanced convenience and compliance, prolonged duration of action, and there will be additive target organ protection. So with all this in mind, let's see what the guidelines tell us. And indeed, a host of guidelines came since 2017. And if we look at the AHA SCC guideline, which came out in 2017, their recommendation was for initiation of antihypertensive drug therapy. The first-line agents should include a thiazide diuretic, calcium channel blocker, AC inhibitors, or ARB. Now, if we look at the ESC guideline, one interesting thing is that with their initial therapy, they decided on a dual combination. So the first, they started with a combination therapy. And what was that combination? AC or ARB with a calcium channel blocker or a diuretic. However, they also pointed out for some patients, they were willing to start with a single drug rather than a dual therapy. And those were patients who were above the age of 80, those patients who were very frail, or the patients whose blood pressure was not that elevated. So the rationale for starting with a combination pill was because the vast majority of our patients will not be controlled with a single drug only. The vast majority will require 2 or more drugs. Now, if that does not work, in the second step, they went for a triple combination, AC or ARB plus a calcium channel blocker and a diuretic. After this, if this didn't work, they went to the third step. And the third step was they deemed it as resistant hypertension when the patient was already on an AC inhibitor or a ARB and a dihydropyridine calcium channel blocker, mostly an amlodipine, and a diuretic. So at this point, they called it a resistant hypertension, and they added spironolactone or another diuretic or an alpha blocker or a beta blocker. But one thing about beta blockers that they cautioned is that we should consider using beta blocker in the treatment step anytime if we thought that our patient had heart failure, was suffering from angina, was a patient of post-MI, had atrial fibrillation, or a young woman who was planning to become pregnant. Now, if we look at the International Society of Hypertension's guideline, so they are very clean-cut advices that first you start with lifestyle modification. However, if your patient comes with a blood pressure more than 160 by 100, you immediately do not wait, you just start the regimen of treatment. However, if the patient is deemed as hypertensive, but the blood pressure is between 140 by 159 and 90 by 99, does not have any comorbidities, we can wait for at least 3 to 6 months and advocate lifestyle modification. Now, here is the trick. You really have to promote lifestyle modification. You just can't say, okay, you need to reduce weight, you need to stop smoking, don't take salt. No one's going to listen to that. You have to reinforce it again and again, and only then would the patient listen. However, if the patient has comorbidities, we need to start the drug as soon as possible. Could you help me again with the slides, please? It's stuck. Could you just move the slide again for me, please? Thank you. Right, the one before, please. Yes. So now in the International Society of Hypertension, they first in the step 1 used dual low dose combination, which was AC or ARB with the calcium channel blocker. For step 2, they, instead of going to 3-drug combination, they went to the maximum of dual drug combination. In step 3, they used a triple drug combination where they added the diuretic, and for step 4, it was adding the spironolactone, and to also consult a specialist. Now, here is the most interesting part. What are we doing in Bangladesh? And I'm so proud of this slide, actually. So in Bangladesh, for primary healthcare setting, where blood pressure is measured to all adults above the age of 18, if you find that there is persistent raised blood pressure above 140 to 159 and diastolic above 90 to 99, then first of all, lifestyle modification is advocated. If the lifestyle modification does not work and you wait and then you start, after a month, you start the medications. Now, what medications have been advocated in the primary healthcare setting? First is you start with a single dose of amlodipine, 5 milligrams once daily. You wait for a month, the patient comes. After a month, if still the blood pressure is elevated, with the amlodipine, you add 50 milligrams of losartan potassium. You advise the patient to continue his lifestyle modification, take these 2 drugs, and then again, after a month, the patient comes. If still the blood pressure is not controlled, 5 milligrams of amlodipine, 50 milligrams of losartan, and 12.5 milligrams of hydrochlorothiazide. Even after this, if the blood pressure is not controlled after a month, you should refer this patient to a specialist. And here, one point we need to notice that we will never ever give a female of childbearing age losartan. If her blood pressure is not controlled by 5 milligrams of amlodipine, we will top it and go to 10 milligrams. And we will not ever prescribe losartan to any female who has the potential of becoming pregnant. And here I want to draw your attention to the lower panel, and you can see 3 logos. So one is from the NCDC Control Center of the DGS of Bangladesh. The next logo is National Heart Foundation, and the third logo is of Resolve to Save Lives. So what is Resolve to Save Lives? Resolve to Save Lives is an international organization funded by different organizations and core organizations like WHO, the World Bank, this vital strategies they supported. And this organization aims to save 100 million lives in the next 3 years. And they have a very interesting logo. Look at it. So it says, now we all know that globally, hypertension is controlled only among 14% of the population. The rest is not controlled. Now, if you can raise that 14% to 50%, so if you can properly control 50% of the population from hypertension, and you can reduce their intake of sodium by 30%. Remember, in Bangladesh, people are taking 10 grams of salt every day. So if you can reduce that to even 7 grams, and if you can stop them having artificial trans fat to 0, then you can save 100 million people in 30 years. So that is where 50 plus 30 becomes 100. And this the non-communicable disease control of DGS, National Heart Foundation, and Resolve to Save Lives have had a MOU, a tri-party MOU, to address this. And how did they start this? First of all, on a pilot phase, 4 upajelas of Sylhet were taken, and here the measure was to strengthen the primary healthcare system for delivering antihypertensive screening, detection and treatment, and most important, follow-up services to the patients. And this pilot phase was of 2 years, 3 months duration, ended in December 2020. And currently, in 54 upajelas of Sylhet, Kishorganj, Jamalpur, the scale-up phase is undertaken, and we aim to control, detect, and treat hypertensive patients in 54 upajelas. So how do they do this? So to strengthen the service delivery, the nurses are trained, the doctors are trained. A standard treatment protocol is adopted for primary healthcare everywhere. The prescription, the algorithm that I showed, first you start with amlodipine, then you move from amlodipine to losartan, then you go to hydrochloride. That protocol, and with 1 month difference, you go on doing that. And all the patients, initially their records were paper-based. From February 2020, an app has been devised, which is called the Simple app, which notes the patient, what kind of tablets he's taking, and if he is late, he or she is late for a follow-up, then it goes, the app sets an alarm, and from the primary healthcare service, they telephone that patient to ask them to come over to collect their drugs and to have their blood pressure measured. And in the pilot project, 29,000 hypertensive patients were registered. And this is the photo of the Memorandum of Understanding and the inaugural scale-up project in February 2021. Most of the people joined virtually at that time. And these are a few photos from the strengthened NCD corners of the primary healthcare centers. So they've really done a great job of it. And I must congratulate Professor Sohail Reza Chaudhry, who's leading this. He's not here, maybe he's watching this, but I'm so very proud of the work that he and the others are doing from National Heart Foundation. And as you can see, the patient very proudly holding his book. This book is like a passport, the blood pressure passport. Each patient is given a book where his blood pressure is recorded, his investigations are recorded, and what tablets he's taking is recorded. And the fantastic news is that in the pilot project, when they started the pilot project, only 12% of the population of that 4 upazila had their hypertension under control. 12%, and of the population, study population, and the study population was around 29,000 patients. And by the end of 2 years, they had gone up to 45%. From 12%, 45% of the hypertensives had their blood pressure under control. This really means that you are making an impact and you're saving lives. And I think of the very different works that National Heart Foundation has been doing over the years, this is one of the best projects that is really going to make an impact long-term for the health of the people of Bangladesh. And with that, I would like to say thank you for being so patient with our bells and sounds and extra music that you have been given. And thank you. Thank you for being with us.
Thank you, madam. Thank you for the elaborate lecture and giving us an insight into the result study. Now, finally, our for the last presentation, Dr. Mir Ishakuzaman. His topic is going to be hypertension in special situations.
Honorable chairpersons, respected panel of experts, Assalamu alaikum. I'm Dr. Mir Ishakuzaman, going to have a talk on hypertension in special situations. 10 to 25% of patients attend in the emergency department with a severe hypertension or uncontrolled hypertension. Then we face the questions whether to admit these patients with aim of quick reductions with IV antihypertensive or just discharge the patient with oral medication. These patients generally have these precipitants and risk factors like non-adherence to medical treatment and inadequate treatment of chronic hypertensions. And they may also use the other medications or illicit drugs that can elevate the blood pressures. Among other risk factors, the male gender, black race, low socioeconomic status, obesity, smoking are there, and the secondary cause of hypertension can also be found. So, underlying pathophysiology of hypertensive emergency is loss of autoregulation, which results in vasoconstrictions and endothelial dysfunctions, causing arteriolar fibrinoid necrosis, eventually end organ ischemia develops. So, how to approach to these patients with hypertensive crisis? We need to find out whether the patients have acute hypertension mediated organ dysfunctions or not by taking proper clinical history, meticulous physical examinations, fundoscope examinations, and other investigations to rule out secondary causes of hypertension or target organ damage. So, after doing that, we can easily group these patients into hypertensive emergency who have associated acute hypertension mediated organ dysfunctions. These patients should be admitted and IV antihypertensive should be started. And other group, hypertensive urgency, who have not acute hypertension mediated organ dysfunctions, they can easily discharge with oral medications with proper follow-up. So these are clinical spectrum of hypertensive emergency, like malignant hypertension, hypertensive encephalopathy, hypertensive thrombotic microangiopathy, patients with severe hypertension associated with other clinical conditions, patients with pheochromocytoma crisis, and the pregnant woman who presents with severe hypertension or preeclampsia, eclampsia complex. So what is the treatment of hypertensive emergency? So the goal is to reduce blood pressure in very controlled way with reductions of 25% of mean arterial pressure over minutes to hours. After first 24 hours, for the reductions over day 2 weeks in order to reset autoregulatory mechanism. But there are exceptions like aortic dissections, pulmonary edema, acute coronary syndrome, post-operative bleeding. So if we look at the isolated, and so we can see the malignant, in case of malignant hypertension, we can reduce the blood pressure slowly for over several hours. The labetalol and nicodipine are the drug of choice. And in case of neurological manifestations like hypertensive encephalopathy, we need to reduce blood pressure immediately with 20 to 25% of mean arterial pressure. Here's again, labetalol and nicodipine are the drug of choice. But in case of stroke, whether it is ischemic or hemorrhagic, we should not intervene blood pressure until and unless the pressure is too high. If it is more than 220 millimeter of mercury in case of both stroke, but in case of ischemic stroke, if we plan to thrombolize the patients, then we need to target at less than 180 over 105 millimeter of mercury for at least the first 24 hours after thrombolysis. In case of cardiovascular manifestations, in case of acute coronary event and acute cardiogenic pulmonary edema, we need to reduce the blood pressure immediately with systolic blood pressure to less than 140 millimeter of mercury. But in acute aortic dissections, we need to reduce systolic blood pressure to 120 millimeter of mercury and also heart rate to less than 60 beats per minute. And in pregnant women, eclampsia and preeclampsia, we need to reduce also here immediately. The labetalol or nicodipine and magnesium sulfates are drug of choice, and delivery is considered often. So if you look at the prognosis of a patients with hypertensive crisis is poor if it is untreated, but 10-year survival is around 70% in modern era. So the next, we go to the topic hypertension in pregnancy. Hypertensive disorders in pregnancy affect 5 to 10% of pregnancies worldwide, and it's still remain a major cause of maternal, fetal, and neonatal morbidity and mortality. So how to approach? So hypertension in pregnancy usually may develop before 20 weeks of pregnancy or after 20 weeks of pregnancy. So if it develops before 20 weeks of pregnancy, we call it chronic hypertension or pre-existing hypertensions. And if it develops more after 20 weeks of pregnancy, we call it gestational hypertension. Gestational hypertension may proceed to preeclampsia in case of 5 to 25%, preeclampsia with or without health syndrome, or eclampsia. Preeclampsia, eclampsia, along with severe hypertension when it is more than 160 over 110 millimeter of mercury, these patients should be admitted. So what to do? So the approach will be, so at first we need to take proper history, physical examinations, and look for the risk factors for preeclampsia. These are hypertension in previous pregnancy, CKD, chronic kidney disease, connective tissue disorder like SLE, antiphospholipid antibody syndrome, type 1 or type 2 diabetes, chronic hypertension, first pregnancy, age more than 40 years, pregnancy intervals of more than 10 years, obese, family history of preeclampsia and multiple pregnancy. These patients should be given aspirin along with other medications. All the investigations are targeted to look for the preeclampsia and eclampsia. Also, there are some there are some investigations which predict the development of preeclampsia, like serum uric acid, Doppler ultrasound of uterine arteries, and a soluble FMS like tyrosine kinase 1:2 placental growth factor ratio. So the goal of the drug treatment of hypertension in pregnancy is to reduce the maternal risk, but we think about the fetus too. So European guidelines have recommended initiating drug treatment in all women with pre-existing hypertension with persistent elevations of blood pressure more than 150/95, in women with gestational hypertension with or without proteinuria, pre-existing hypertension with the superimposition of gestational hypertension, or hypertension with subclinical hypertension-mediated organ disease when the blood pressure is more than 140/90. As already we have, sirs and madam, already discussed about the drugs that ACE inhibitors, ARBs, and direct renin inhibitors are contraindicated in the pregnant woman. So methyl dopa, labetalol, and calcium channel blocker are the drugs of choice. Beta blockers may induce fetal bradycardia. Consequently, if used, the type and dose should be carefully selected, with atenolol best avoided. Diuretic therapy is generally avoided because plasma volume is reduced in women who develop preeclampsia. A target should be less than 140/90 is suggested for pregnant women receiving antihypertensive. Women who develop gestational hypertension or preeclampsia are at increased risk of hypertension, stroke, and ischemic heart disease in later adult life. So annual visits to primary care physicians to check blood pressure and metabolic factors are recommended for these patients. And then lastly, we'll look at the resistant hypertensions. We know this hypertension is defined as resistant when the target of BP control cannot be achieved despite of appropriate lifestyle measures, treatment with optimal or best tolerated dose of 3 or more drugs. We should include a diuretics with typically an ACE inhibitors or an ARB and a calcium channel blocker. And the inadequate control of BP is confirmed by ambulatory blood pressure monitoring or home blood pressure monitoring in patients whose adherence to therapy has been confirmed. The true prevalence of resistant hypertension is less than 10% because most of the cases, the patients present with apparent resistance hypertensions. So the clinical characteristics of them are older age, obesity, more common in Black people, excess dietary sodium intake, high baseline blood pressure and chronicity of uncontrolled hypertension, and existence of concomitant disease like left ventricular hypertrophy, chronic kidney disease, diabetes, atherosclerotic vascular disease, aortic stiffening, and isolated systolic hypertension. So the approach, at first, we need to confirm the treatment resistance. Like office blood pressure should be more than 140/90, and the 3 antihypertensive medications should be prescribed in optimal dose with including diuretics, or the patient's blood pressure is controlled with more than 4 antihypertensive medications. Then we need to exclude the pseudo-resistance. So at first, we need to ensure accurate office BP measurement to exclude the white coat hypertensions and assess treatment adherence. And then we need to identify and manage reversible conditions like lifestyle factors, obesity, excessive alcohol or high sodium intake, intake of vasopressor or sodium retaining substances, obstructive sleep apnea, and oral contraception. Then we need to screen for undetected secondary causes of hypertension and target organ damage. The treatment, again, the reinforcement of lifestyle measures, as the Professor Fazilatunasa Malik Madam already beautifully described it, so I won't go through it. So then the discontinuation of interfering substances and the sequential addition of antihypertensive drugs to the initial triple therapy, ultimately replacing all current drugs by a simpler treatment regimen using single pill combination treatment is recommended to reduce pill burden and improve adherence to treatment. So add-on drugs, addition of low-dose spironolactone to existing treatment, or the addition of further diuretic therapy if intolerant to spironolactone with either eplerenone, amiloride, a higher dose of thiazide or thiazide like diuretics, or a loop diuretics, or maybe we can add the addition, we can add the bisoprolol, even we can use the other potent vasodilators like minoxidil. Renal denervation and carotid baroreceptor pacing can be used, though studies have not provided sufficient evidence. And here I stop. Thank you. Thanks for patience hearing.
Thank you, Ishraq. Thank you very much for that elaborate discussion. Now, at this point, I would go to our respected panelists who are with us very patiently for a long time. And I would request them for very quick comments and opinions. So I can see in the panel, there was Professor Abdul Qadir Akondo, sir. Sir, are you with us? Professor Amol Kumar Chaudhuri, sir. Professor Tripti, sir.
Yes. Hello. Can you hear me?
Yes, sir, we can hear you.
Okay. Thank you very much, Honorable Chairperson and eminent speakers and distinguished panelists. Good evening to you all. And warm greetings on the eve of World Heart Day, because this program is especially designed before World Heart Day. And this year's theme is use heart to connect. And I like to explain it in the spirit of this theme that in Bangla, that is Nijer heart sustha rakhun, shobar sathe jukto thakun. And why use heart to connect? Because in this COVID-19 pandemic, people are really scared to go out and for doctor's visit and investigation as well. So if you want to go out and go to physician or healthcare professionals, definitely you will mean the diagnosis of hypertension. That's why we all need to connect each other. And in this regard, I think this program will play a tremendous role. That I must thank to organizers, because hypertension is the number, I think, is the most important risk factor for cardiovascular disease and most important preventable cause and of premature morbidity and mortality. So if we don't go out, if we don't go to the physicians or getting investigations properly, then we miss the proper diagnosis of hypertension. So I think this webinar, it will play a tremendous role to aware and to educate our junior fellows as well. So, and in this regard, one more things I like to thank Professor Fazila Malik and other National Heart Foundations, that they are doing a tremendous job in respect of management of hypertension protocol and the new project. And I wish their success. And if this project is successful, then what she told us, that about more than 40% people will be treated, that is hypertension free. So with these few words, I like to conclude, because already long list of panelists here, and already we have passed 1.5 hours. So thank you very much for inviting me. And I think it's a great honor for me to be here with you. Thank you very much.
Thank you very much, sir. Professor Ranjit Khan, sir, is with us. Sir, your valuable comments, please.
very much, Honorable Chairperson, moderator, and the speakers. The program is very elaborate, and A to Z of hypertension has mentioned in this topics. Dr. Professor Dhiman Bonik has mentioned the person who has 140/90, they should be evaluated for the next time, and treatment should be given if it persists. And if it is 180/110, then there is no need to further evaluation. But sometimes we face problem during our practice. The first time the patient shows his blood pressure is 150 and diastolic is 105. At that time, it is very difficult to wait for the next time. Then we have to give some medicine then. Whether it is wise or not, you can mention it. The Professor Fazilatun Malik, as usual, she makes the audience spellbound at his lecture. And it will be very beautiful if they can put this audio video in the YouTube. A lot of doctors will be helpful with this program. Thank you very much, everyone. And right, thank you.
Thank you very much, sir. Professor M.G. Azom, are you with us? Professor Prabir Kumar Das, sir, would you please give your valuable comments?
Hello, can you hear me?
Sir, yes, sir.
Am I audible?
Sir.
So thanks to respected President, learned presenters, panelists, and the National Heart Foundation Authority to organize such a program. I am glad to hear that the project on hypertension is being run by National Heart Foundation. What I think that hypertension is somewhat neglected in our country. There is Diabetic Association, there is Hospital on Diabetes, there is the World Heart Diabetic Day is nationally celebrated. But to my utter surprise, tomorrow is World Heart Day, but this is not in fact a national day. It is not celebrated nationally. And hypertension is still neglected because there is no institute on hypertension. There is no even society on hypertension. What works are being done on hypertension is done by National Heart Foundation. And the beautiful project is being run by National Heart Foundation, as Dr. Fazilatun Malik mentioned. And our population, what I think is they take a lot of salt and they are salt sensitive. As we know, the hypertension in blacks are a special entity. And what I think that our population, Bangladeshi population, is in between blacks and the Western whites. So we have some peculiarities and some special attributes in our patients with having hypertension. Regarding their treatment, regarding their lifestyle modification, use of salt, and everything. So these things are being, I think, will be highlighted, will be given appropriate attention, is being given appropriate attention in the project as being beautifully run by National Heart Foundation. So tomorrow is World Heart Day, and the most important risk factor is hypertension for heart diseases. As we know, the heart diseases are the #1 killer. And in this COVID situation, using digital health is the theme of this World Heart Day. So what I think that the project as being run by National Heart Foundation can use some digital platform like messaging, use of various apps and digital apps, and by making our population aware and giving mass information through messaging from this project, so that the people are being conscious regarding their use of salt. You'll be seeing that most of the hotels, they start with the people taking in hotel and in some household in their personal dining table, they start with taking salt. So which is unthinkable in prevention of hypertension. If you want to prevent hypertension, if you want to save our population from hypertension, we must reduce salt intake. And this is only possible by giving bulk message to our population through this digital health service, as insisted by World Health Day, which will be celebrated tomorrow. So with these few words, I give thanks to the organizer, presenter. Thank you all.
Thank you for your very kind words. I just want to clarify one thing. So Heart Foundation is one of the parts of this project. The drugs are being completely supplied by the People's Republic of Bangladesh, because this is a tri-party understanding. So Heart Foundation is there. Then the non-communicable disease control of the DGDS is there, and the Resolve to Save Life is giving technical and some funding support as well. So three bodies together, so united, this thing is happening. And by Heart Foundation is obviously very, very happy and proud to be associated with this great endeavor of the Ministry of Health of Bangladesh. So it's a thing. So three bodies together, coming together, and this thing is happening.
Madam, National Heart Foundation is taking the initiative. So great initiative, and very heartfelt thanks to the Heart Foundation. Thank you, Madam.
Thank you very much, sir. Now I would like to request Professor Mohammad Shahabuddin, sir, to say a few words.
Thank you very much. This is an excellent presentation on hypertension. It includes everything from beginning of the hypertension, definition, classification, and lastly, treatment option and the treatment in special situations. And the projects, that is pilot projects run by the Heart Foundation and Government of Bangladesh. As I am in Sylhet, I am also a part of this project. I have taken several times with the decision making and in planning implantation of this project. And this project is running in Sylhet in rural area. You will be very much surprised that the most of the hypertension patients goes to the clinic and they take the medicine regularly from the clinics and then come again to our hospitals to see that they are taking these medications, and 100% of the patients are taking the medication from these clinics. This is an excellent program, and I think this program will be successful all over the Bangladesh if it is disseminated to all the upuzelas of Bangladesh. Thank you very much, madams. Thank you very much, sir, for taking the initiatives along with the government of Bangladesh and others organizations. And today's webinar was a very successful one. I think this program will go successfully again and again. Thank you very much, sir, madam, and all the participants that are with us. Thank you very much.
Thank you, sir. Dr. Professor Taufikur Rahman Farooq, are you with us? Now I would like to request Professor M. Badiuzzzaman sir to say a few words.
Thank you, Dr. Taufik Shahid, and thank you everyone, and thank you all the four speakers. They have done a very brilliant job, especially the lecturer Professor Fazila Malik. They have enlightened us about the work we are doing along with the government of Bangladesh and Resolve together. It was a really surprising news that they have done a great job controlling 50% of hypertension in rural population. That's a very great number, because internationally, as we know, the number is only 14%, even in the developed world. In that, relative to that, 50% controlling 50% of patient hypertension is really a great achievement by this group. I hope that this work will go on, and it will be reflected to other parts of the nation also, and also whole world. Actually, I think the motivation, as Dr. Prabir Kumar has really correctly mentioned, diabetes is quite nationally, internationally projected every day and in our print media or electronic media. But hypertension, I think it is quite neglected. I think we should have a separate institute like Bardem having hypertension for diabetes, so that we can reach to our people with hypertension and motivate them to control their blood pressure. And I think that will help us, because once it was said, there was a study long back, I don't remember the name of the study. That study, it was probably Atlas. The study was Atlas. They were claiming that if you compare between diabetes and hypertension is more dangerous than diabetes as a disease in long term. So I think we should take more care of our hypertension patients. And thank you very much all the speakers, Dr. Taufik, Dr. Ashok Kumar, and Dr. Shahid Zaman and Madam. Thank you very much. And thank you all the other panelists who have joined us in this conference. Thank you very much.
Thank you, sir. Thank you very much. Professor Nazir Ahmed, sir, are you with us? Professor Nazir Ahmed, sir. Yes.
Yes. Thank you very much. It's a very wonderful session and very wonderful presentation by all speakers. And I like to thank everyone. Hello. I like to thank everyone. Do you hear me, please?
Sir, শুনতে পাচ্ছি, sir.
Yeah. Hello. Yeah. I want to say something about the lifestyle motivation mentioned Professor Fazila Mali. That is, the exercise is one of the very important thing for control of the hypertension. Exercise, at least most of the days of the week, is very important. At least 4 to 5 days a week is very important. At least 30 minutes to 45 minutes a day. What are the importance of exercise? Especially walking is very important. Number one is it reduces the HDL level. It increases the collaterals of the blood vessels, and also it improves the cardiac functions and peripheral vasculatures. And it also very important for endorphin hormone is secreted during exercise. It creates euphoria, feeling of well-being during exercise. And that's why exercise is very important. Madam already mentioned it. And I like to thank everyone because it's a very good presentation, and all speakers, Dr. Diman Monik, Ashok, Dr. Fazilatunnisha Malik, and Dr. Ishaq Jaman has mentioned all the things about the hypertension. Thank you very much. Thank you all.
Thank you, sir. Professor Amal Kumar Choudhury, sir. A few words from you, sir, please.
Thank you, Dr. Tawfiq, for inviting me to give the opportunity a few words. I was actually with this program from beginning to now. I have learned from many things, and I think it is a composite, basic and advanced seminar, not webinar. It is a seminar on hypertension from our delighted Madam Fazila, Madam, to Ashok Datta and all other speakers. No stone unturned about the management and about the pros and cons of hypertension. I think it will be beneficial if every peripheral doctors who are first dealing with the hypertension, if they got the link and attend. I think they will be very much very. Me also learn most of the things that I like to forget from this seminar. Thank you. I think every topic was very important and nothing to tell about the silent killer, which is the very target. All the target organ give rise to handicap of the patient. Brain, stroke, blindness, heart attack, CKD, all hypertension, nephropathy, all not only personal life. It is very burden and very bad situation, create a bad situation of the family, society, and also the country. Thank you to arranging this seminar. Thank you, Heart Foundation. It's my heartfelt thanks to the Heart Foundation to arrange the detailed program on the day of World Hypertension Day, just 1 day before. Thank you.
Thank you very much, sir. Now, I would like to request Mr. Faizul Hafiz from Navana Pharma to make his presentation on improving patient compliance, a major goal in management of hypertension.
Honorable chairpersons, the panel of experts, and the distinguished guests, as well as the respected professors. Assalamu alaikum and very good evening. Thank you so much, and I'm very privileged that I have got this opportunity to talk in front of all of you. And today, I'm going to talk about a topic, and that is the improving patients' compliance, a major goal in the management of the hypertension. I'm Faizul Hafiz, Brand Executive, Strategic Brand Management Department, Navana Pharmaceuticals Limited. We already know that Amlodipine is a very wonderful and time-tested drug, but we also know that out of 4 patients, every single patient experience the pedal edema. So though Amlodipine is a wonderful and time-tested drug, due to the pedal edema, the patient compliance of Amlodipine is very poor. So how Amlodipine causes the pedal edema is very simple. We know that Amlodipine is a mixture of 2 enantiomer, that is the S enantiomer and the R enantiomer. S enantiomer is basically giving the therapeutic efficacy, whereas the R enantiomer is responsible for the pedal edema. So the racemic amlodipine or conventional amlodipine contains the R amlodipine, which is ultimately responsible for producing the nitric oxide, and the synthesis of nitric oxide is ultimately responsible for the pre-capillary vasodilation. So it dilates the arterioles only, not the venules. So ultimately what happened, it causes the expulsion of the fluid into the surrounding tissues, and we considered it as the pedal edema or the ankle edema. So what should be the alternative drug instead of the amlodipine? So the drug should be more efficacious or similar efficacy as the amlodipine, and of course negligible incidence of pedal edema. So considering these features, Navana Pharmaceuticals have proudly introduced us first time in Bangladesh 1.25 milligram and 5 milligram, that is the L-Amlo. The brand name is L-Amlo and the generic is Lev-Amlodipine or S-Amlodipine 1.25, 2.5 and 5 milligram. And our slogan is better compliance as negligible edema. So it has got the FDA approval on December 20, 2019, and the originator company is CSPC Pharmaceutical Group. Lev-Amlodipine is available in many countries like the USA, the India, Russia, Brazil, Turkey, and many other countries. It is indicated for the treatment of hypertension in adults and pediatric patients 6 years and older to lower the blood pressure. The doses and administration is very simple. Adult recommended starting dose is 2.5 milligram orally once daily, and can be maximized up to 5 milligram. And for the small, fragile or elderly patients and the pediatric patients, the starting dose is 1.25 milligram, and it can be up to 2.5 milligram once daily. There are some data about the pharmacokinetics of the Levam Ludipine, that peak plasma concentration is 6 to 12 hours, absolute bioavailability 64 to 90%, plasma protein binding 93%, metabolism through the hepatic metabolism is 10%, and urine 60%. Half-life of Levam or L-amlo is 30 to 50 hours. Levam inhibits the L-type calcium channels in vascular smooth muscle, reducing peripheral vascular resistance and blood pressure. And the patients should be counseled regarding the risk of symptomatic hypotension, worsening angina, and myocardial infarction. The warning and precautions of levoamlodipine, the patients who are severe aortic stenosis, the patients who have severe aortic stenosis can experience the symptomatic hypertension and the worsening angina and acute myocardial infarction. The dose should be titrated slowly in patients with the severe hepatic impairment. So for the use in a specific population, pregnancy, the data is very limited, and the use in pregnant women are not sufficient to inform a drug associated risk for major birth defects and miscarriage. And for the lactation, no adverse effects of levoamlodipine on the breastfed infant have been observed. So we are talking about the pedal edema, and we are telling that the amlodipine is causing the pedal edema, but not the levoamlodipine, because levoamlodipine only contains the S-amlodipine. So we know that amlodipine contains the R-amlodipine. That R-amlodipine is basically responsible for the pedal edema, but as levoamlodipine or L-amlo does not contain any R-amlodipine, only the amlodipine, so it only gives the therapeutic efficacy and does not cause any pedal edema. So there are some clinical studies. It shows that 2.5 milligram and 5 milligram levoamlodipine versus 5 to 10 milligram amlodipine, and it shows that the levoamlodipine significantly reduces or manages the hypertension, the SBP, basically better than the amlodipine, and also the DBP better than the amlodipine. So it shows better efficacy at half dose if I compare with the amlodipine. Incidence of pedal edema with the amlodipine almost 41.9%. That is near about 42% patient experiences pedal edema with the amlodipine, but with the levoamlodipine, only 1.92% or near about 2% people experience the pedal edema. So we can confirm that it almost, levoamlodipine or L-amlo, that is confirms almost negligible edema compared to the conventional or racemic amlodipine. If we see the equivalent therapeutic dose, that 1.25 milligram levoamlodipine is equivalent to 2.5 milligram amlodipine. Similarly, 2.5 milligram levoamlodipine is equivalent to 5 milligram amlodipine, and 5 milligram levoamlodipine is equivalent to 10 milligram amlodipine. So those patients who are taking the amlodipine, they don't need to take the other part of the amlodipine, that is the inert part of the amlodipine. This is the pack shot of our product. We have 3 strength, the 1.25, 2.5, and 5 milligram L-amlo, that is levoamlodipine. It's very, we try to make it very affordable for the patients as well. For the L-amlo 1.25 milligram, the pack size is 30s, that is 30 tablets will be there, and the MRP is only 120 taka. For 2.5 milligram, that is 210 taka, and for 5 milligram, that is 270 taka. So this is very affordable for the patient. There are some references, and I would like to conclude my presentation here, and thanks all of you for your patience hearing. Thank you so much.
Thank you, Mr. Fazul Hafiz. Now, vote of thanks will be delivered on behalf of Navana Pharmaceuticals by Professor Junaid Shafiq, Managing Director of the company. Professor Junaid Shafiq, please. Sir, kindly unmute.
Assalamu alaikum. Thank you all for joining the webinar on hypertension. I, on behalf of Navana Pharma. Hope that you have enjoyed the program and will continue supporting Navana Pharma in future. I thank National Heart Foundation of Bangladesh for organizing this program in World Heart Day. Thank you all for joining this program. Keep well. Thanks, everyone.
It must be very early in the morning.
It's
Thank
very
you.
early. I'm in New York. It's very early.
Thank you very much, sir, for joining us.
Yeah.
I would now like to request Professor Khandekar Abdullah Rizvi, sir, to leave a few concluding remarks and conclude the program. Sir, please. Kindly unmute.
Thank you, Sharia, for conducting this meeting very nicely. Of course, and initially there was some technical problem. I hope next time there will not be any technical problem. The National Heart Foundation. I'm looking to that. I would like to thank all the presenters for their beautiful presentation, and they have covered almost everything about this hypertension, and that was necessary. That lectures have enlightened us a lot. I would like to thank my heartfelt gratitude and thanks to all the panelists for their participation and for their contribution. They have contributed a lot. They have mentioned a few of these important issues about this prevention of this heart foundation, and many of them has lauded the role of National Heart Foundation of Bangladesh. National Heart Foundation, you know, is trying their best to help the people of Bangladesh to maintain their cardiac health. And, you know, we have also involved not only with cardiac health, we are also involved with non-communicable diseases. And Brigadier Malik sir has formed a national body, we call it PNCCP, that has included almost all the major professional bodies. And we also work with other people to prevent smoking. Anti-smoking campaign is also strong from National Heart Foundation of Bangladesh. Regarding the resolve our activities at the Pujala level, the joint activities with the government and resolve. In fact, this has proved to be very tremendous. And the initial our pilot project was excellent and proved to be very successful because the data they have produced is almost 45% now is they call it taking drugs regularly and could control the blood pressure, 45%. That was only 12% in the past. So I am very hopeful. And we are also, regarding the compliance of the drug, this gentleman presented a paper and has mentioned about this compliance. Compliance is very important, especially in the case of hypertension. For the compliance, one thing is very important, that is motivation. That is educating the patient about the disease, about the importance of the drugs, and about the possible complications. So every physician should try to educate their patients so that the compliance can be easier. Second important issue about the compliance is the drug price of the drug. So Professor Fuzila has mentioned that whenever possible, we should try to use the cheapest possible drugs so the patient can buy those drugs. Of course, there are drugs, newer drugs, which is slightly expensive. As for example, I do not know the price of this drug. The Navana company has coming up with a new drug which will cause less ankle edema. Sometimes, of course, the expensive drug may be required. in our project with the result, the drug is given free by the government. And now at this moment, the drug is given at the Upazila Health Complex. Sometimes the patients has to travel a long distance to go to Upazila Health Complex to procure the drugs. So we have proposed to the government that these drugs, anti-hypertensive drugs, should be supplied from the community health clinic. That means the village clinic. So if that is possible, then we will be able to help the patients a lot, so that the compliance would be more easily complied. So we are also trying in that respect. Anyway, this is an ongoing drive. We are always trying to educate the patient. Somebody has also emphasized the importance of salt. We are also working with salt. We are also working with the trans fat. Our epidemiological department is very active. Inshallah, we will continue our project. In this meeting, I was the only Junaid Sofik also, non-cardiologist physician. Junaid, only 2 people are here. They are not cardiologists, and almost everybody and other persons of your organization. As a physician, I'm still a practicing physician. I see a lot of patients. Many of the patients to come to us, and as well as Junaid with the neck pain, young patient with the neck pain, and patient is trying different modalities to treatment for this neck pain, but in fact the neck pain is due to hypertension. Nobody has checked the blood pressure. Patient has seen several doctors. Nobody has checked the blood pressure. So this is very important to check blood pressure for in every adult, whoever it is the orthopedic surgeon, or it is a joint pain specialist, or a general physician, or anybody, any patient seeing a doctor, it should be mandatory to check his blood pressure if the patient is adult. And similarly, I have seen many elderly patients coming to us with back pains and neck pains and other body pains, body aches and everything. If we check the blood pressure, you will see blood pressure is 118 and 110. And they do not know they have blood pressure. They have never been treated. And somebody was treated, but not taking the drugs, because somebody said the blood pressure is okay. So this is a sad stories we sometimes see in our society. Anyway, if everybody try hard to overcome these taboos and this misunderstanding, then hopefully we'll be able to fight this hypertension in our country. With these few words, thanking everybody, I would like to thank you from myself and from National Heart Foundation to all the presenters, to all the panelists, the sponsor, Navana Pharmaceuticals and Junaid Sofik, have joined from America in the early morning. And so thank you. And to all the participants who have participated. Thank you.